This explainer is based on autoimmune inner ear disease, AIED, a vestibular physician's deeper view published by Australian Dizziness Clinics, available at australiandizzinessclinics.com.
Welcome back, vestibular physicians, neurootologists, audiologists, and advanced trainees. Today, we're navigating the clinical workflow for diagnosing autoimmune inner ear disease, or AIED. It's a rare but profoundly treatable condition. And because it lacks a single definitive pathognomonic test, our diagnostic approach has to be incredibly precise, highly evidence-based, and completely authoritative. Here is our roadmap for today. We're going to cover investigating suspected AIED, the audiological backbone, quantifying vestibular involvement, serology screening, mandatory imaging, and finally, our key takeaways. Okay, let's dive right into this, starting with Section 1, Investigating Suspected AIED. This quote really hits the nail on the head right from the jump. Over-investigation, it rarely actually changes your management in AID. Since there's no single magical test that just confirms this disease for us, every single investigation you order needs to have a clear rule-in or rule-out purpose. We are looking to document dysfunction, track the treatment response, or rigorously, and I mean rigorously, exclude mimics. Moving right along to Section 2, the audiological backbone. Pure tone and speech audiometry form the absolute diagnostic backbone here. But here's the absolutely crucial point. This testing must be serial. Fluctuation and steroid responsiveness have to be actively demonstrated over time. We cannot just assume them from a single snapshot in the clinic. You're often going to see speech discrimination scores deteriorate way out of proportion to pure tone thresholds. That pattern is a huge signal for neural involvement, and it carries real prognostic weight. Plus, otoacoustic emissions, or OAEs, give us a highly sensitive, really early index of outer hair cell function, which can change incredibly rapidly during active disease. And this brilliantly illustrates exactly what we're looking for. Notice the solid line representing the active disease, and then compare that to the dotted line, which shows a documented partial recovery after a corticosteroid trial. Actually seeing this documented partial recovery over weeks or months is highly suggestive of an AIED. It's exactly why a single audiogram is never, ever enough to establish or rule out the diagnosis. Let's head into the vestibular lab for Section 3, Quantifying Vestibular Involvement. So up to half of AID patients are going to have vestibular involvement, but honestly, it's frequently indolent and totally clinically silent. Because of that, we rely heavily on the Video Head Impulse Test, or VHIT, and Vestibular Evoked Myogenic Potentials, or VEMPs. We absolutely need these tools to objectively measure and detect the deficits that the patient might not even acutely report to you. This specific vestibular test panel is a critical piece of your workup. Caloric testing and VHIT, they quantify canal function and are essential for detecting that sneaky subclinical bilateral loss. Meanwhile, cervical and ocular VEMPs add incredibly valuable information on otolith organ function, which might reveal some hidden asymmetries. Doing this vestibular testing serially really helps you distinguish a progressive immune vestibulopathy from a deficit that's just stable and static. All right, let's shift to blood work. Section 4, Serology Screening and the Systemic Check. So grouping tests by their actual purpose here. On one hand, we've got inner ear specific testing, historically the anti-HSP70 Western blot. Now, it's positive in about half of clinically active patients, sure, but its specificity is pretty limited and honestly, it just isn't widely available. On the other hand, a full systemic screen is an absolute necessity. Why? Because roughly a third of these patients actually have a systemic autoimmune disorder, so you must run an anti-nuclear antibody, or ANA, anti-neutrophil cytoplasmic antibody, or ANCA, rheumatoid factor, ESR, CRP, and crucially treponemal serology. You have to run these to detect secondary AID and completely exclude treatable dangerous mimics like autosyphilis. Now, what's absolutely critical to understand here, this is a fundamental rule. AIED remains a clinical diagnosis. Positive inner ear serology supports it, absolutely, but negative serology does not exclude it. A negative or unavailable assay must never, ever delay a steroid trial. Withholding treatment while you're just sitting around waiting for labs in a compatible clinical picture, that is a major red flag that seriously compromises patient outcomes. We just can't do it. Which brings us to radiology. Section 5, Mandatory Imaging to Exclude Mimics. Now, I know we established earlier that over-investigation isn't helpful, but this specific imaging is completely non-negotiable. A gadolinium MRI of the internal auditory meatus is mandatory at first presentation. You simply have to exclude vestibular schwannoma, endolymphatic sac tumors, demyelination, and any other structural pathology before you can confidently proceed with an AIED diagnosis. Let's look at how all these elements build into one cohesive clinical algorithm. It's kind of like a giant puzzle coming together. First, you identify that bilateral progressive clinical picture. Then, you deploy your serial audiometry, your mandatory gadolinium MRI, your systemic and treponemal serology screen, and those vestibular tests we talked about. You vigorously exclude all those mimics, and finally, you move to the corticosteroid trial, which, remember, serves as both a diagnostic and a therapeutic tool, and you retest that audiogram. If they respond, AIED is confirmed.
Wrapping things up with Section 6, key takeaways and the diagnostic funnel.
To really solidify what we've covered in this explainer today, first, serial audiometry is your diagnostic backbone. Fluctuation has to be actively documented, never just assumed. Second, inner ear serology is supportive only. But a systemic and treponemal screen, that's absolutely essential to detect secondary disease and exclude mimics. And third, a gadolinium MRI is mandatory at presentation to rule out vestibular schwannoma and any structural pathology, no exceptions.
So, what does all this mean for our patients? In our next explainer, we're going to examine management, steroids, steroid-sparing agents, and biologics. Because the real question is, how do we transition from confirming this incredibly rare disease to effectively stopping permanent bilateral deafness dead in its tracks? Visit AustralianDizzinessClinics.com for the full review and all the companion materials. Thank you so much for learning with us today, and we will see you in the next explainer.